the economics of early childhood obesity prevention. And today we'll have the pleasure of hearing from three of our CRE member stars, all experts in health economics and all experts within the economics of obesity prevention in early life, I guess a niche within the health economics frame. Today our three speakers will discuss the latest economic advances that we're making, the challenges that we're facing, and we'll spend some time discussing the future research that's needed to achieve effective and cost-effective obesity prevention from the start of life. Before we start today's proceedings, let's take a moment to acknowledge the traditional custodians of the lands from which we're both presenting today and viewing this webinar from, and to pay our respects to the local peoples, their elders past, present and in the future. Just by way of housekeeping, we're going to save questions for the end of this session, but please feel free to post questions in the chat as they come to you, because you might forget, and we'll try to cover these at the end. So we'll start today's session by introducing Dr. Vicky Brown. Vicky is an Alfred Deakin postdoctoral research fellow at Deakin Health Economics within the Institute for Health Transformation at Deakin, Melbourne, Australia. So over to you, Vicky.
Thank you, Karen, and thank you and welcome to everybody attending today. So today we're presenting on the work of Stream 3 of the NHMRC funded Centre for Research Excellence in the Early Prevention of Obesity in Childhood, or EPOCH CRE, which began in 2017 and is led by Professor Louise Bauer. So the CRE is organised into 4 streams, as you can see on the slide there. And today we'd like to share with you some of the work that we've been undertaking, really aiming to expand the economic evidence for early childhood obesity prevention intervention. Before jumping in, we'd like to acknowledge all of our CRE members who come from a range of institutions, as you can see on the slide there. And we have pictures from our 2019 annual meeting, back when we could cluster together on a staircase like that. And then of course our virtual annual meeting last year. We'd particularly like to acknowledge the economic stream leads from the CRE, who have been really instrumental in developing all of the presenters that you'll hear from today. So Professor Marge Moody from Deakin Health Economics at Deakin University, and Associate Professor Alison Hayes from the School of Public Health at the University of Sydney. So really brief background, 1 in 4 Australian children are classified with overweight or obesity before they reach school. We know that those from low socioeconomic groups are affected more than those in high groups. Overweight and obesity in childhood are associated with health effects during childhood, and they're obviously a risk factor for several chronic conditions that generally present a little bit later in life. We think that early childhood presents this key time for investment in obesity prevention, and it's really all about improving the health of children from that very young age and then setting them up to lead happy, healthy lives. So evidence from the literature suggests that obesity tracks from childhood to adulthood, and that children and adolescents with obesity are 5 times more likely to experience obesity as adults. We had a recent study just on the bottom of that slide there that was led by Alison, and it looked at the tracking of overweight between early childhood and adolescence and found much lower tracking in the early years, so before about the age of 7, suggesting that this could be when children are most amenable to intervention. So when we're thinking about interventions, it's really important that we direct our scarce health resources to those which represent the best value for money. And so economics can help in resource allocation and decision making in a number of ways. So the first is around estimating costs. So we can estimate the costs of overweight and obesity. And these estimates are useful to gauge the extent of the problem economically, and they can be really powerful tools for advocacy. We can also estimate the cost of intervention or the downstream cost savings that might result. But costs are just one side of the equation. And while cost information is useful, as health economists, we're most concerned with both the costs and the benefits of intervention, and using these to estimate cost effectiveness through economic evaluation. So the types of costs related to overweight and obesity can include direct costs, so for example, healthcare costs, such as hospital services or GP visits, and they also include indirect costs. So for example, productivity costs, as carers might be absent from work due to caring responsibilities, or perhaps they're present at work but not as productive as they might otherwise have been. And we think that early childhood overweight and obesity is quite costly to society. So we have some evidence that the healthcare costs of young children with overweight and obesity are higher than their healthy weight counterparts. So there was an Australian study that found that the excess Medicare costs for high BMI were evident from about the age of 4 years onwards. And in an early piece of CRE related work led by Alison, the healthcare costs of preschoolers with obesity were found to be over 1.5 times that of children with healthy weight. And we took these findings and we extrapolated them nationally, estimating that the annual direct costs to the Australian healthcare system are quite high at around $17 million. As for indirect costs, at the moment we've got pretty limited evidence on indirect costs by weight status within this preschool age group, such as whether there are those productivity costs of parents or carers, or perhaps other indirect costs, maybe costs associated with loss of educational attainment or child development. And clearly there's a pretty significant opportunity here to generate and to build on this evidence. And we have a number of trials at the moment that are attached to the CRE that are exploring some of these issues. So turning now to the costs of intervention and understanding the costs of different interventions in a way that means that we can compare these costs meaningfully can help to maximise efficiencies. So resources used in interventions fall into different cost categories, such as personnel or time costs, pharmaceutical and health technology costs, transportation costs, and intervention-related buildings, infrastructure and equipment. And up until recently, there wasn't a lot of information that was publicly available in terms of how much early childhood obesity prevention interventions might cost. And the cost information that did exist wasn't particularly comparable, as the estimates had all been arrived at in a variety of different ways. So we decided to make use of the opportunity that the CRE presented, in that it brought together investigators from 5 pretty well-known early childhood obesity prevention interventions. And we developed this consistent costing methodology that we then applied across all 5 interventions so that we could estimate comparable costs. The 5 interventions that were included in this piece of work were the prevention of overweight in infancy, or POI intervention, which was conducted in New Zealand and delivered a sleep, food, activity, breastfeeding or combination intervention delivered in home or group settings. The Nourish nutrition intervention was delivered in group settings in Queensland and South Australia. Infant is a Victorian intervention delivered in group settings. Healthy Beginnings was a home visitation intervention in New South Wales, and the Communicating Healthy Beginnings Advice by Telephone or chat intervention took the learnings from Healthy Beginnings and delivered them via telephone or SMS intervention arms. And the results from this specific piece of work are presented here. So we've got the different intervention arms along the x-axis. And the intervention costs have been broken down into cost categories. So we've got equipment costs in green, travel costs in orange, and the time costs in blue there. And we can see that there's quite a lot of variation between intervention costs. So the Healthy Beginnings home visiting intervention was the most costly at just over $1,100 per participant. And the chat SMS intervention arm was the least costly at around $80 per participant. So most of the interventions were under $500 per participant, and the variation in cost was primarily driven by the mode of intervention delivery and the associated time costs required. And we can see that those blue time costs make up a pretty significant proportion of total cost for all of the interventions. We also found that while delivering an intervention by telephone might perhaps be thought of as less resource intensive. In the case of the chat telephone intervention arm, and that's the one with the green star there, quite a lot of labour time was spent trying to connect with participants over the phone. And this made the intervention perhaps a little bit more resource intensive than might have otherwise been expected. So I guess in a nutshell, by estimating the comparable costs of intervention, we can not only provide information that's relevant to funders and policymakers, we can also provide evidence that trialists can consider when designing and implementing their interventions. But as I mentioned previously, costs are only one side of the equation, and what we're most interested in is intervention cost effectiveness, which we determine through economic evaluation. So economic evaluation can help us answer pretty classic resource allocation decision problems like the one on this slide. And it involves the explicit comparison of the costs and benefits between at least two alternatives, really so that this information can be used to get the best value for money from our spend as possible. While there are several types of economic evaluation, in health we generally use these two, so cost effectiveness analysis and cost utility analysis. In cost effectiveness, in both the costs are valued in monetary terms. Cost effectiveness analysis values outcomes measured in natural units, so might be BMI units avoided. In cost utility analysis, the outcomes incorporate impacts on both quality and quantity of life. And a commonly used metric is the quality adjusted life year, or the QALY. Now, the use of a common metric like the QALY means that it's easier to compare cost effectiveness across different interventions, so they can be in quite different disease areas. And another benefit of using a metric like the QALY is that we have these relatively well agreed upon thresholds for cost effectiveness. So in Australia, we generally say that interventions are cost effective if they're less than $50,000 per QALY. Economic evaluations can be undertaken as either within trial or modelled economic evaluations. So within trial evaluations use data on the costs and effects that are collected within a trial, and they estimate cost effectiveness over the time horizon of that trial. Modelled economic evaluations can use data from trials or other sources from the literature. And they're useful in predicting the costs and effects that aren't measured directly. So modelling is really useful when we're interested in costs and benefits over a longer time period than within trial. And this is particularly useful in prevention, obviously, when major benefits are often incurred sort of off into the future. So the way that we formalise the value for money of either within trial or modelled economic evaluations is with this metric called the incremental cost effectiveness ratio, or the ICER. So calculating the ICER is relatively simple. We divide the difference in total costs between an intervention and its comparator by the difference in the health outcomes. And the lower the ICER, the better the value for money. And there's just a few examples on the slide there of what an ICER might look like for a cost effectiveness or a cost utility analysis, respectively. We've got time for a quick quiz now. And in a moment, a quiz question will pop up on your screen. And you'll be able to answer by clicking on the checkbox next to whichever answer you think is correct. So which of these interventions represent the best value for money? We've got a healthy eating intervention at $800 per BMI unit avoided, a home visiting intervention at $750 per BMI unit avoided. We have a multi-component intervention with an ICER of $900, and a telephone intervention with an ICER of $725 per BMI unit avoided. So I'll just give you a moment to add in your answer and then we'll have a look at results. Got a few more coming in, so maybe we'll present results in just one moment. And there we have the results. So remembering that the lower the ISA, the better the value for money. So well done to all of those people that picked the telephone intervention there. Okay, moving back on now. Okay, so we're going to turn back to our work now after we had that, brief dip into what was pretty much Health Economics 101. So there's pretty clear gaps in the evidence for the cost effectiveness of early childhood obesity prevention interventions. And these are the gaps that we were aware of at the beginning of the CRE a few years back. So firstly, at that time, there were very few published economic evaluations that had been undertaken. So there was a systematic review back in 2016 that found only 6 published economic evaluations, 2 of which were within trial economic evaluations, and 4 were modelled, with all of those 4 being modelled over the entire lifetime of the child population. This means that there was virtually no evidence counting the sort of midterm costs and benefits, or counting the costs and benefits from early childhood to adolescence, which might be a particularly policy relevant time frame. Of the studies that existed, they all used different methods, and so comparability between the results was quite challenging. And there was virtually no work exploring the differences in cost effectiveness by socioeconomic group, specifically in this preschool age group. And so this is where our work fits in. And Annika and Michelle will now go on to introduce how we have built a health economic model to evaluate interventions over the childhood to adolescence timeframe. We've used the model so far to undertake 2 economic evaluations, and we've explored the equity impacts on cost effectiveness. And I'll now hand over to Annika, who will introduce the EPOCH model.
Thanks, Vicky. I'm just going to share my screen. Choosing the wrong one. Sorry. All right, so I'm actually going to this short video introduce the model that we developed, and I'm going to then give you a bit more detail about it straight after. So as described in the video, there are 3 components to the EPOCH model. So we've got the BMI trajectory part, the cost model, and the quality of life part of the model. And with each of these outcomes available, this means we can do both that cost effectiveness and cost utility analysis that Vicky talked about. So first focusing on the BMI trajectory part of the model. To test whether this model works, we validated the predicted results on the original data. So here we've got presented mean BMI trajectories by starting weight status. And you can see that the predicted BMI in the dotted lines here matches quite closely with the circles, which shows us the real data from LSAC in all 3 weight groups. And as part of my PhD, I've also developed a version of the EPOCH model that predicts BMI trajectories by socioeconomic status. And again, this model predicts the actual data from LSAC quite well for both BMI trajectories on the left and for prevalence of overweight and obesity on the right. So this version of the model will help us conduct SES-specific economic evaluations and consider the impacts of interventions on inequalities. So now looking at the quality of life part of the EPOCH model. So for economic evaluation, we need a specific type of quality of life measure called utility. And this is a number between 0 and 1, where 0 represents death and 1 represents full health. So to incorporate this into our model, we needed to know what the average utilities for each weight group were for children. So in a study led by Vicky, she conducted a systematic review around this question. And after meta-analyzing the 11 studies that she found these small but significant reductions in utility with overweight and obesity compared to healthy weight. However, there was some heterogeneity between the included studies. And so to delve into this relationship a bit further, we analysed the longitudinal data from LSAC. And I'm not going to go into a lot of detail with this study, but the main takeaway was that the association between weight and utility was different in boys and girls. So in girls, this relationship strengthened with age. So that meant that older girls had greater decrements in utility with high weight status than younger girls. However, in boys, the association was weaker than in girls, and it didn't change with age. Now looking at costs in the EPOCH model. As with utilities, we needed to be able to incorporate healthcare costs per person for healthy weight, overweight, and obesity. And that's what we've shown here in this graph on the left. So to estimate these figures, we used national data on hospital expenditure, Medicare costs, and prevalence of overweight in these 4 age groups here on the left. We also used published data on the relative differences in costs for children with overweight and obesity compared to healthy weight, and then applied these relative costs to the national data in order to get these annual per person costs. So in summary, the EPOCH model can tell us about BMI, quality of life, healthcare costs, and non-version socioeconomic inequalities in obesity from the childhood and adolescent period, or throughout that childhood and adolescent period. So with each of these outcomes available, as I mentioned earlier, this means we can use the model to conduct both cost effectiveness and cost utility analysis. So cost effectiveness analysis will give us a cost per BMI unit avoided, and cost utility will give us a cost per quality gained. So we've conducted these analyses using the model for 2 interventions, that's POI and ROMP and CHOMP. And today, Michelle and I will talk about the base case results of these analyses, but there's a lot more detail in the publications. So starting with POI, this is the Prevention in Infancy Intervention trial. Prevention of Overweight in Infancy intervention. This was a randomized control trial headed by Rachel Taylor and Barry Taylor in New Zealand. And our colleague Andrew Tan, pictured here, led the economic evaluation. So POI was a 4-arm trial. which recruited women at the later stages of their pregnancy, and interventions were carried out up until the child was 2 years of age. So the usual care arm involved a standard well-child service offered to all infants in New Zealand. The sleep arm was an intervention around healthy infant sleep behaviours, and this involved one group session and one home visit as a standard for all participants. And then there was an optional component to this intervention with 4 different levels of intensity. Then we have the FAB arm, otherwise known as the FAB, physical activity and breastfeeding intervention. And this involved 8 contacts as a standard for all participants. And this was a mix of home visits and GP sessions. And finally, we have the FAB and sleep arm, which was a combined intervention, including both sleep and FAB components. So in our economic evaluation, we only assessed the sleep and combined arms compared to usual care. And that's because the FAB arm showed limited effectiveness at the 2-year and 5-year follow-ups. So the aim of this economic evaluation was to determine the costs and cost effectiveness of the POI sleep intervention arm alone and in combination with FAB compared with usual care from the perspective of the healthcare funder and within a policy relevant timeframe. And here I've just shown the publication resulting from this evaluation if you want to look into this. So first, as part of this evaluation, we determined the intervention costs of both arms using that same common costing protocol that Vicky mentioned earlier. So this incorporated time costs of trial staff, which included administrative training and intervention delivery time, travel costs for staff going to the group sessions and to participant homes, and intervention material costs. So that includes venue hire and information handouts. So taking all of this into account, we worked out that the average cost per participant in the sleep arm was $184 per person. And for the combined intervention, it was $601 per person. Then looking at the intervention effects, the trial results showed that both the sleep and the combo arm were effective at lowering BMI at age 5 compared to the control arm. There's a lot more detailed effectiveness results reported in these 2 publications. And for those who are interested, these are all the relevant technical details of the economic evaluation. The main thing you need to know here is that we conducted both that cost effectiveness and cost utility analysis using the EPOCH model. So here are the results of the POI evaluation. So these are the results after we modeled the BMI outcomes from age 5 out until adolescence using the EPOCH model. So for both the cost effectiveness and cost utility analyses, you can see that the value for money was better in the sleep only arm compared to the combo arm. And we can tell that by the lower ICEs in the sleep versus the combo. And using that accepted $50,000 per QALY gained threshold for cost effectiveness, the sleep arm had a 74% probability of being cost effective when accounting for uncertainty in the results. So overall, the sleep intervention alone was found to be cost effective, whereas the combo intervention was not cost effective. And using the SES specific model, I've also conducted an analysis of the effects of socioeconomic status on the cost effectiveness of the sleep only arm. And what we found here was that the intervention ended up being less cost effective in the low SES group compared to the high SES group, although both ICEs still fell under that $50,000 per QALY gained threshold for cost effectiveness. And there was still moderate probability of the intervention being cost effective in the low SES group. So the key findings from this evaluation was that the sleep intervention was low cost and cost effective, whereas the combined intervention was more costly and not cost effective. And finally, socioeconomic status had a clear impact on the cost effectiveness of the sleep-only intervention. So now I'm going to hand over to Michelle, who's going to tell us about the romp and jump economic evaluation.
Thank you, Annika. And I'll be talking about the second economic evaluation we did using the EPOCH model, which is we use this EPOCH model to evaluate the cost effectiveness of romp and jump interventions. Romp and jump was a community-wide obesity prevention interventions targeting children aged from birth to 5 years. The intervention was conducted in 2004 to 2006 across the city of Greater Geelong and boroughs of Queenscliff. The aims are to improve eating and physical activity environments via community capacity building and sustainable changes in environmental settings in early childhood, education and care settings. This intervention used a repeat cross-sectional quasi-experimental design to measure intervention effects. The aim of our research is to answer the questions from a funder's perspective. If the romp and jump intervention is to be delivered nationally to all Australian children aged from birth to 5 years, will these interventions be cost effective compared to a no intervention comparator? This evaluation is quite different from POINT in that we took costs and effects from the trial and hypothetically extrapolate them to the whole population of Australian children aged from birth to 5 years. We costed the interventions based on trial records using common costing protocol as mentioned by Vicky. The intervention has 3 different cost categories as described before in Annika's slides. The cost per participant averages out to be $93. Romp and jump was effective at reducing BMI in children aged 3.5 years compared to the no intervention group. The reduced BMI was 0.06 unit. If you are interested in the details of the trial and the effect size, you can refer to the published paper shown on the slides. This slide contained all the technical details of all the parameters we use in our economic evaluations for those who are interested, but we won't be going into details today. We conducted a cost effectiveness analysis and cost utility analysis. Results from our cost effectiveness analysis shows that the mean cost per BMI unit avoided is slightly over $1,100. Results from our cost utility analysis shows that the mean cost per QALY gained is $26,400. This intervention has a 64% probability of being cost effective compared to the $50,000 threshold. So using the same costing and modeling techniques, we are able to compare the cost effectiveness results of the POINT interventions and romp and jump interventions. Both POINT sleep interventions and romp and jump are cost effective. However, romp and jump is more affordable given lower intervention cost per participant. This is because the romp and jump intervention resources was less intensive than POINT, and we assume that interventions materials were delivered online. So to sum up, early interventions played a key part in helping children to achieve healthy weight and maximize their quality of life later in childhood and adolescence. Our research showed that we need more economic evaluations to inform comprehensive childhood obesity prevention strategy. We have evidence to show that some of the effective obesity prevention interventions represent good value for money, such as the POINT sleep interventions and romp and jump, which means that they are worth investing in. We recommend the incorporation of a sleep modification component in future early childhood obesity prevention interventions, and romp and jump should be integrated as part of a healthy eating and physical activity policies in childcare settings. And lastly, as we've pointed out earlier, that there are different cost effectiveness results between different socioeconomic groups in the evaluations of POINT. Therefore, it is important that we investigate these issues further in future research. So what are the next steps that we can take from here? We definitely can use EPOCH model to evaluate the cost effectiveness of early childhood obesity prevention initiatives. We need more explorations of the cost effectiveness of early childhood obesity prevention interventions, especially in the vulnerable populations. So then you may ask, how can I help? You can help by consulting with a health economist when designing your trial and incorporating economic evaluations in your study. Information regarding resources required for intervention delivery need to be rigorously and routinely collected. And this is the end of our presentation for today. We would like to acknowledge the NHMRC for funding this research, the participant of the trial, and the trial research team. Thank you for your listening, and I'll hand over to Karen.
You're on mute, Karen. Sorry, we can't hear you. No, we seem to have lost.
Perhaps one of the rest of you could oversee that while Karen's sorting out her mute.
Yeah, sure. So we'll move to questions now. And there were a few in the chat that we can touch on first of all. So there was a question in regards to the SES economic evaluation of the POI intervention. Annika, so why is it less cost effective in the low SES group?
Yeah, I just had a look and I let it basically guess the answer to that. It turned out to be mainly driven by the differences in effect size in between the groups. So there was slightly more costs in the low SES group, but it was mainly that the intervention effect size was lower in the low SES group.
Vicky, would you like me to add to that? It's Rachel.
Yes.
My question was why? Why was the effect size lower, or why? Like, do you know why?
Yeah,
it was
yeah. So I mean, this is work we've been doing for quite some while, because of course this was the POI kids are now 11 years of age. So when we set up POI, it was very much using the sort of standard sleep recommendations that exist. And we know now that many of these recommendations really don't fit the lived realities of many of our participants' lives, particularly for us in New Zealand in our Māori and Pacifica communities, you know, asking people to put a baby down in a separate room in their own bed in a quiet, dark place doesn't work if you spend a lot of time at the marae or have a very busy, full household and all those sorts of things. So, I mean, they simply didn't resonate, a lot of those messages, with many in the lower socioeconomic community. And so the work that we're doing now is very much working with our Māori and Pacifica providers to develop sleep messages that fit their lives, that have the ability to actually make a difference. And it'll be interesting to see with an RCT that we'll get going later this year, whether that will make a difference.
Great. I will just note there that we did have some tech problems around the model video, which is a shame because it's pretty cool. So we will send a link out with the recording of the webinar to everybody so that you can have a look at that, because I think it's a really nice summary that Annika put together on how the model works.
Sorry about that.
But no, I think obviously your internet probably couldn't handle it for a minute there and the slides got a bit blurry, but yeah, the joys of working from home, I guess.
Yeah.
Yeah. So we've got another question from Karen. While I understand the cost effectiveness was modelled on BMI, is it reasonable to consider the effects on other health behaviours and health outcomes? For example, if a combo influenced dietary or physical activity behaviours or outcomes, this potential effect might not be recognised. While there could be some overlaps in biological explanations, perhaps not all covered. And I would wholeheartely agree with that. So yeah, so obviously our model looks at the outcomes of BMI, health-related quality of life, and healthcare cost. But obviously we know that these early childhood obesity prevention interventions can deliver some other really important outcomes that aren't included at the moment. So I have started a postdoc project looking at some of the other outcomes from early childhood obesity prevention interventions. And we'll be developing a core outcome set and then looking at, I guess, the preferences and the value of some of these different outcomes between different stakeholder groups. But it's definitely an area where more needs to be done because they are, you know, we know these interventions do other things as well. So good question.
Thanks, Vicky. And Amanda, can you hear me now?
Yes, we can. Yeah.
Sorry, I put my phone on to take no calls, and I think so. Apologies, and I really did want to say a big thank you to because it's easy for us to stand here and listen. It's actually very nerve-wracking to present, and wonderful job. And look at, I guess, even beyond traditional health behaviours, like I guess some of the stuff around social connection within service delivery, with reconnecting with community in other ways. I think there's a whole lot of stuff we haven't measured particularly well, which I'd love to be able to see as accommodating economic models over time. So great work.
Karen, I think that's a good prime example with POI too, because of course we assumed that the mechanism for the obesity was improved sleep, because of course that was the whole point of the sleep intervention. But our measures don't show an improvement in sleep at all. And so there's another explanation there of which we're still, you know, not sure. We think it's coming down to some changes in parenting that we've observed. But yeah, even if you can measure some behaviours, you're not necessarily measuring them ideally or the best way, and they still may not be the things of interest either.
Yeah, I think that's a great point, Rachel. And one of the, you know, not a well-measured outcome, so anecdotal, but one of the things that maternal and child health nurses report with infant is that because they tend to run those group sessions in the local library or other community venues, that they feel that participants, particularly those who wouldn't normally have found it, are more likely to feel comfortable and come back and use it. So if you use libraries as an example, as a segue to opportunities for reading, for instance, the explanations could lie totally somewhere else. So interesting, lots of good things for us to think about.
Karen, there's a question from Ellie Howes, I think would be worth, shall I read it?
Yes, if you could, sorry.
Yes, so Ellie has asked, how do you account for an equity component to this as well, e.g. cost-effective interventions that support low SCS groups that are much more equitable? So I don't know if Annika would like to talk about how you could account for equity.
Yeah, so we've been thinking about this and how to interpret these results that we found with the POI evaluation. And what we're not saying with this evaluation that, you know, we should only be targeting the high SES group because it's more cost effective there. This is more about showing what sort of trade-offs will be made by where we're targeting the intervention. So potentially by targeting a low SES group, we still have a cost-effective intervention there, but we are having some sort of trade-off between having the cost-effectiveness we would in a high SES group, but improving equity because we're targeting the group that's more in need. So yeah, I guess this model and the valuations that we can come up with that is just going to make it clear what sort of trade-offs between equity and cost effectiveness will create. I hope that answers that question.
And can I pick up on a couple of questions from Penny Love, also down at IPAN at Deakin. So Penny's asked two questions. So one is about the high equipment cost in infant and any comments about why it was higher than other interventions like Nourish. So that's, I guess, directly for Vicky. And the other question or comment from Penny was, I guess a question to Rachel, is there a component of POI that's EC based, which could be used for the comparison? So that's, I think, a question perhaps to Annika.
Shall I jump in first? So yeah, in terms of the costing work that we did of the 5 interventions, we costed them as they occurred within the trial at the time that they occurred. So if you remember back to that slide, some of those interventions were conducted some time ago. So we looked at the, equipment that was used within the different trials, and there were some differences at that time. But I think in subsequent iterations, particularly some of these interventions, obviously time's moved on, and perhaps a lot of the resources now are being made available more electronically or online or things like that. So probably an important clarification that they were costed as they occurred at the time that they occurred. And, there were some differences.
Yeah, and in terms of POI, there was no ECE component because the prime POI intervention was only from 0 to 6 months of age. That was a sort of sleep problem prevention program. And then at 6 months of age, we asked the parents if they felt their child had a sleep problem, and if yes, would they like some additional help? And while about, it was just under half, 40% say their child had a sleep problem, only about a quarter took on board any additional help. And so because the intervention was predominantly focused on that 0 to 6 month age group, we didn't have an ECE component just because of the age.
Okay, so there's a question here from Wei Kwan asking, is there any modelling around the cost effectiveness of doing an intervention targeting lower SES populations across the life course, so lower SES versus higher SES?
There is. I was also part of another CRE in the ACE obesity policy team. So I think Anita is on this webinar. She had a PhD that was looking at adapting the ACE obesity policy model, which models over that longer life course kind of approach, and adapting that by socioeconomic position. So we had used that model for a couple of different interventions, not specifically within this kind of preschool age group, but yes, certainly some of that work exists. So there was a modelled economic evaluation over the lifetime for sugar sweetened beverage taxation. And I also did one around restricting television advertising to children.
Thanks, Vicky. And Megan Hunt asks, she's wondering if there's a database or list of research that can be used to assist the why argument when sourcing funding for local projects. So I guess this is, providing rationale to line managers within local government. Is that, I think that's what Megan's asking.
Yeah, I mean, that's a good question. And I think it's, it would be a really handy resource that could potentially come from some of this work that we've been doing within the CRE. So we are currently working on some kind of, plain language summaries of the work that might be useful in that sort of work. But yeah, I think that's a really important area that, and a resource that could be put together.
Yeah, and that segues quite well to Ellie's comment about highlighting all the other positive outcomes from these interventions as being important for policymakers. And I guess that goes strongly to understanding what the policy levers are at any point in time, because it's not always, whilst cost is clearly fundamental and centre and the key to sustainability over time, it's sometimes not the first thing on front of mind, and so it'd be lovely to be able to bring all of these things together. How are we going on questions? Louise, you might be able to pick up questions that I'm not grabbing. There's quite a lot. I'm not like a radio announcer and can read the emails as well as remember to speak.
Folk, if you've got things, if you want to actually make additional comments to those which have been put on chat, please put your hand up or just come on board, and we anticipate that you won't be too unruly. Yes, and I think a number of these have been answered. Could I ask myself, actually it could be any of you could answer this. Most of these interventions, well, maybe particularly not so much Romp and Chop, but the others have been somewhat more focused interventions rather than lots of multi-component elements of it. Romp and Chop may be a little bit different. And yet we probably, if we're thinking about real life interventions, we're probably thinking about a number of things. So, something that's supporting sleep, something that may be supporting breastfeeding, something that may be supporting families in other settings. And I was wondering if one of you could comment upon the challenges in trying to put all these bits of information together to try to work out what those costs may be, or what may be potential new interventions that we could think about. I think that's a bit of a broad-based question, but I don't know if one or more of you would like to answer that. I might hand over to Vicky first, because I can see her face smiling more than the others.
Oh, I was just thinking, just a simple question to answer then, Louise.
And I'm compelled as the chair or as the moderator to say you've got 8 minutes.
Oh, okay. Yeah, I mean, I think that's a good point. And we know that, no one single intervention is going to be the answer, and that some of these more systems approaches, targeting multiple different things, and, over the life course as well, is really important. In terms of how we do it, it's obviously pretty complex and complicated when you're trying to attach costs and benefits and to come up with these sorts of evaluations. But there is some work starting to happen or occurring in that area. But yeah, I guess my short answer would be it's pretty complicated. It's complex, and it's probably not something that we've got a perfect answer for yet, but certainly aware of, and I guess working towards trying to be able to cobble those things together, and to then also look across the life course in terms of providing this kind of information. I'm not sure if I've answered that question, but I don't know if Annika or Michelle, you want to jump in?
Complicated sounds about right. I guess I'd hope that Top Child, which was discussed in the last webinar, would help us tease out those details, and hopefully we can get a bit of cost data from that analysis as well to be able to do some more.
Fantastic, thanks. Can I ask Lena, do you want to actually pop your microphone on and ask us your question?
Oh yes, no, it's prompted by the POI results, which are a bit surprising in that adding more to the sleep intervention seemed to, if anything, reduce the impact and certainly increase the cost. So obviously that was not a good move, but there's always some uncertainty, of course, in the results, and as discussed, not all the population groups were equally well served, probably by the design of that intervention. So my question was, at what point do you say, yes, this is cost effective? At what point would you say further investment is needed for a confirmation trial? Because I mean, you've always got, by chance, some of your interventions or intervention arms will come out better than others. Is it too early to accept those, or should we be more careful?
It's a good question. I'd probably say yes. It'd be great to do this trial again, maybe with more data in a different setting, in different contexts. All we can really say that is in this trial, it was the sleep intervention was cost effective, and the combined was not. We did do bootstrapping and uncertainty analysis around it as well. We just couldn't show all that detail today, but yes, I'd say we do need a bit. It would be great to be able to do this trial in a bigger.
Oh well, we await further news from New Zealand, I understand. So thanks. Good presentation, by the way.
I mean, I don't think there's any issue about these results, because we've now shown it at 3 ages that the sleep group are significantly better off than the non-sleep group, but it's only a single trial, and that's always a problem. You always need additional trials to actually suggest anything, and there's actually been very few sleep interventions. The Insight trial in the US had a sleep component, but they didn't have an individual sleep group, but their sleep and solids intervention also shows some benefit, including long-term once the intervention cease. But there's actually been, they're kind of the only, and then there's Chat have included it as part of theirs, but it's a component as well rather than a separate arm. So, there really isn't much research in the sleep actual intervention space from an obesity prevention point of view. There is a bit in the sleep problem literature. So infants with sleep problems are put under an intervention and just happen to have had BMI measured, and so they've had a bit of a look at that, but they weren't designed in the sort of same way. So we're very much missing some sleep intervention research.
Thank you, Rachel.
I wouldn't be repeating POI, as I said. It wasn't, you know, it's 11 years ago, we'd design it quite differently now.
Yes, wouldn't we all?
Yeah.
Rachel, thanks for that. We've got just a couple of minutes left, and I see that Penny Love has had her hand up, so apologies, Penny. I'm finding it difficult to negotiate all the different inputs here. So over to you, Penny.
That's okay. So probably one comment and one question. The comment was about the complexity. I would agree. I don't think it's complicated, but it's certainly complex. And I think the continuity of message across maternal child health and into the different settings that our young children go to, like early childcare, is what's important. My question is in terms of I'm excited to see Romp and Chomp back on the agenda and to see such great results. I'm a bit cautious though for us to be comparing that with the other trials that we've been talking about, because it's delivered quite differently through an ECEC, whereas the other trials, to my understanding, is predominantly through our health service. But I'd certainly be quite excited to see how we could bridge that gap, given that our children then are exposed to two different sectors, and we'd like them to be saying the same consistent message around infant feeding and sleep and activity. That's probably it.
And Penny, can I just jump in on that, the end of your question, or the end of your comment? It is interesting. I'm not sure if Romp and Chomp has been scaled up, but if it hasn't, it's an interesting example perhaps of an effective trial or an efficacious trial may not get picked up and run, and there's just a whole lot of other levers in there that we need to be aware of. So yeah, it may be being run, I'm not sure.
No, it stopped. My understanding was that the Healthy Together Victoria initiative was the big driver. So when that stopped, there were a lot of initiatives that stopped. So
yeah, that's right. And I guess just picking up on what you said, Karen, so obviously the cost effectiveness evidence is one piece of, you know, the puzzle that decision makers and policy makers use when they decide, you know, where resources are allocated. So it's certainly not the be all and end all, but is important evidence to inform that.
Absolutely agree. And on that keynote, health economics needs to be central to all of our research. I'm going to need to close us off. Our hour is up, and so just to finish off, to say again, thanks, big thanks to Annika and Michelle, and to Vicky, to Louise, our leader in chief, and yeah, we look forward to more. Thank you very much for your organisation as well, and all concerned. We'll sign off. Thanks so much.